Hi, this is a short overview of asthma. I'll be talking about the pathophysiology of asthma, the etiology and the triggers of asthma, some signs and symptoms of asthma presentation, the diagnosis of asthma and how to make that diagnosis formally, the management of chronic asthma or recurrent asthma, some drugs that are related to that management, as well as what to do in the case of acute asthma exacerbation. So let's get started. So first, pathophysiology of asthma. Asthma is a reactive obstructive airway disease. There's a combined effect here. There's both bronchoconstriction and inflammation. And you often see asthma with a couple other A's. So you see asthma, atopy, and allergies all together. So this might be a little kid that has like eczema or contact dermatitis. They might also have asthma. So those are all like IgE mediated conditions, and they often come together. So again, IgE mediated, so IgE triggers mast cells that then dump all their granules which contain histamine. So this is an IgE mediated process or a histamine mediated process. And again, it's related to eczema or atopic dermatitis, other conditions like that. Here are some quick figures that show you what asthma does in the lungs. So you have some muscle here in the bronchioles, and you have the airways, and then you have the air sacs at the end, the little alveoli. Before an asthma episode, you have pretty good patent airways here and normal-sized air sacs. After an asthma episode, there's a bunch of mucus in the airways. The muscles all contract, so these are thinning on the inside, and the airways here swell. That's what makes it an obstructive airway disease. The outlet of the airways becomes obstructed with mucus and with bronchoconstriction. So the air that's inside kind of gets trapped and the airways swell. Here's probably a better picture. Your normal airways are this nice open tube surrounded by muscles, and there's an airway wall and nice and open in the cross section. During asthma symptoms, you get a bunch of mucus on the inside. The mucus comes from the inflammation, so that's one of our components here. And then the bronchoconstriction happens, so the airway is now limited, and the muscles are kind of tightening and constricting that airway. So you could see on the cross section that there's a lot less room in the airway. It's now filled with a bunch of mucus from the inflammation, and the bronchoconstriction is creating a thickened airway wall. The muscle is kind of clamping down on the airways. And the result again is that your airways will swell, and it's an obstructive airway disease. So what triggers the inflammation and the bronchoconstriction that we just saw on the previous slide? The base etiology is not known. There's a bunch of triggers that we've identified, and I'll show you a list of those in a second. There's also a lot of associations with asthma that are worth knowing. So nasal polyps is one association, eczema, as we've already said, and patients that tend to have frequent hospitalizations and frequent intubations are more likely to have asthma. So here's the long list of triggers. Asthma can be triggered by a viral infection. This could be RSV or rhinovirus in children. It could just be a common cold that triggers your asthma. Some people have exercise-induced asthma. This is especially common in adolescents or young adults. They start to have these asthma symptoms when they exercise. Allergens, both indoor and outdoor allergens. So you can go outside, run into some pollen, trigger your asthma. You could also have dust mites or cockroaches or other indoor allergens like pet dander that trigger your asthma. Smoke, like cigarette smoke or hookah smoke, can trigger asthma, or campfires even. Particles, so if you work in an industry that has particulate matter, that can trigger asthma. This could also be more smoke particles. Cold air can do it. Some people in different humidities or in different temperatures experience asthma symptoms. Mold can do it, so I guess that's kind of an allergen indoor exposure. Some people seem to get asthma when they're just stressed, and this could be psychological or emotional stress is enough to do it. So it's probably something internal in your body is triggering the inflammation related to your stress response. Acid reflux can trigger asthma, so some people need to avoid certain foods or lying down after meals to avoid getting an asthma attack. Allergic rhinitis can trigger asthma, so if you it's kind of similar to these allergens here. If you're allergic to pollen, you go outside, you get a bunch of pollen in your face from the trees, your nose might swell up, and that might trigger an asthma attack. Catamenial, so asthma can be triggered kind of in conjunction with your menstrual periods, and the hormonal fluctuations that happen during your period can trigger an asthma attack. some organic compounds. This is related to some industrial or occupational exposures that people have, like formaldehyde and some pesticides can trigger asthma. And sometimes you have an asthma exacerbation that has an unknown trigger, so you don't really know what's causing it, unfortunately. So the signs and symptoms of asthma are pretty easy. It's really just this bolded bullet point here. In general, we said asthma is a obstructive lung disease. Air gets in but can't get out. So you will notice when listening to somebody breathe that they have increased respiratory phase of respiration. So when they're breathing, they're going to be spending more time exhaling than a person without asthma would. So again, the important ones: wheezing, shortness of breath, chest tightness, and coughing. We have some audio clips here. You'll be able to hear wheezing. So this is just a couple wheezes. Let me make sure the volume's up. So those are 2 wheezes. This is wheezing, I think, with a bit of coughing. This last sound clip is what wheezing would sound like under a stethoscope. So those sounds are pretty typical of what you would hear in a patient with asthma. Now there's some things that can kind of modify these symptoms. So they're paroxysmal, so they're kind of sudden onset. They happen out of nowhere. Person is fine 1 second, and then maybe a minute or so later they're having all these symptoms at once, and all this wheezing kind of comes out of nowhere. There might be sputum production, there might not be. Sometimes that's related to associated infections that might have triggered the asthma, but the inflammation of asthma itself can also create sputum production. These people might have fevers. That doesn't really help you lead you toward or away from the diagnosis of asthma. It's important to know that if somebody does have a fever, it's harder to detect it using an oral temperature because they're breathing so heavy. So if somebody's breathing heavy and frequently, they're going to kind of report a cooler temperature on oral measurement than normal. So maybe armpit or another way to get the temperature is more helpful here. So if somebody really has difficulty breathing and they're in just frank respiratory distress, we might call that status asthmaticus, and this is characterized by people using accessory muscles, the intercostal muscles in the chest, to help them breathe. On exam, they'll have low lung sounds, or they'll have hyperresonant lung sounds. So because it's an obstructive lung disease, the lungs might sound hyperresonant because air is kind of accumulating in the lungs. So the lungs are pretty big, or pretty like overfilled, and you'll hear hyperresonant lung sounds instead of normal lung sounds. So again, the AAAs are also associated, so that's a noteworthy sign and symptom. You might notice somebody has a rash, has atopic dermatitis, could be a tip-off that they might also have allergies in their airways or asthma. So this is how you'll make the formal diagnosis of asthma. First of all, if a patient, like a young kid, comes in with acute onset of wheezing and shortness of breath, you can just treat it. You don't necessarily need to do all these things before you treat it. So sometimes it's pretty obvious, and experienced clinicians, pediatricians might hear asthma, hear the wheezing, and just know to treat it. That being said, the most accurate test is the pulmonary function test. This is doing spirometry and measuring all these lung volumes that these patients have. First of all, you'll measure the forced expiratory volume in 1 second. That's a measure of the amount of air that a person can blow out of their lungs in 1 second, starting with full lungs. And there's also this forced vital capacity. That's FVC. That's the total amount of air that somebody can exhale, starting with full lungs. Now, if the ratio of these two, as shown here, is low, that suggests active asthma. For that person, in order to confirm asthma, you would give bronchodilators like albuterol, and then you would repeat the test. If the FEV1 improves, and the number cited in the literature is about 12% with albuterol, then you have a diagnosis of asthma. So the important thing to note here is that asthma is reversible with a bronchodilator like albuterol, and that reversibility is indicated by an improvement of FEV1 by 12%. If the FEV1 does not improve when given albuterol, then you can consider another obstructive lung disease. It could be COPD, for instance, it could be bronchiectasis. It's something else. Asthma is typically reversible, so that's needed for the diagnosis. Now, if on the first test the FEV1 to FVC ratio is normal, that suggests no current active lung disease. That doesn't mean that they don't have asthma. It just means that they're not acutely experiencing asthma symptoms. So you can kind of test if they have asthma by giving them methacholine. This is called a methacholine challenge. Now, methacholine is it's like a synthetic analog of acetylcholine, and it has the same effect as histamines, as we discussed earlier. So it'll cause the bronchoconstriction. It'll cause some inflammation in the lungs. So somebody that has normal readings, normal spirometry, give them methacholine, and if the FEV1 drops about 20% with methacholine, then you have a diagnosis of asthma. If FEV1 does not change, then they don't have asthma. They might not have any disease because they had a normal number to begin with, and they still have a normal number after giving them methacholine. Now, this test isn't really done in the clinic. It's kind of cruel to give somebody methacholine. So if somebody has a really obvious acute onset of wheezing and the albuterol makes it better, then you don't necessarily do this to diagnose asthma. Another risk is that methacholine can induce status asthmaticus, which can become a more serious condition. About 1 to 2 patients who get a methacholine challenge will end up with status asthmaticus, so you do want to avoid that. There's other tests that can indicate asthma. You would not do these routinely, but it can help lead you to the diagnosis, and you might do these to kind of rule out other lung conditions. For instance, you might do a chest x-ray to rule out pneumonia, and you might notice on chest x-ray that the patient has lung hyperinflation. So that would be a sign that they might have asthma. On a complete blood count, you might see increased eosinophils. If you're testing the blood for IgE, that might be increased in asthma. You can also do skin testing to allergies, and that can help you find potential triggers. So this is when they take someone's back or arm and they expose them to small amounts of several antigens and find out which ones the body reacts to. If you're actually culturing sputum samples or looking at things under the microscope, you might notice Charcot-Leyden crystals or Kirschmann spirals. This is really just a pathology finding. You wouldn't do this in the clinic to diagnose asthma, but these are characteristic of the disease. Now let's talk about the management of asthma. These next 2 slides are going to be talking about the management of chronic recurrent asthma, and then at the end we'll talk about what to do in the cases of acute exacerbations. So in general, there were 2 main mechanisms of asthma, the bronchoconstriction and the inflammation, and the drugs that you give for it can be broken down into those 2 groups as well. So the anti-bronchoconstriction drugs and the anti-inflammatories. Anti-bronchoconstriction includes short-acting beta agonists, long-acting beta agonists, theophylline, anti-muscarinics, which are also anticholinergics, and anti-leukotriene drugs. The anti-inflammatories are corticosteroids, which you can have them inhaled, so that's inhaled corticosteroids, or you could have oral corticosteroids. We'll talk a bit about the differences and why inhaled might have less systemic side effects than oral corticosteroids, why you might want to avoid orals. There's also anti-leukotrienes in this category as well, so anti-leukotrienes kind of have both effects. And the treatment for somebody with asthma is added in a stepwise fashion depending on the frequency and severity of their asthma. So we'll be talking about the different levels of how bad asthma can get and what you'll do to treat it. So the most mild form of asthma is called intermittent asthma. This is when somebody has daytime symptoms less than twice a week, and they have nighttime symptoms. They might wake up with a fit of asthma less than twice a month. Their FEV1 is greater than 80% of the predicted value, and that predicted value can be based on their height, weight, age. They would only have to use their short-acting beta agonist less than 2 days per week. So that would be their albuterol rescue inhaler that they only use less than 2 days per week. So the treatment for these people would just be to keep them on that short-acting beta agonist. Just give them a rescue inhaler. They're not using it that frequently to be concerned, so you don't need to give them another treatment. The next level is mild persistent asthma. This is people who have daytime symptoms at least twice a week. They might have nighttime symptoms 3 to 4 times per month. They'll again have that predicted FEV1 of greater than 80%, and they'll be using their short-acting beta agonist rescue inhaler at least 2 days per week. And for these people, you would want to, of course, keep them on the short-acting beta agonist inhaler their rescue inhaler, but also add a course of low-dose ICS, low-dose inhaled corticosteroids. So this would be something that they would take regularly, and it's actually pretty important to take the inhaled corticosteroids regularly, but they'll be on a low dose in addition to their rescue inhaler. And it's worth mentioning that these treatments, they're cumulative, so somebody in the mild persistent group would also get the same treatments above. Next is moderate persistent asthma. These people have daytime symptoms every day of the week. They have nighttime symptoms at least once a week, and they have a lower predicted FEV1, so 60 to 80%. They're having to use their rescue inhaler daily, and these people would get a low-dose inhaled corticosteroid as well as a long-acting beta agonist. So those two in addition to their rescue inhaler. And lastly, we have the severe persistent group. These people have symptoms continuously. They have symptoms all the time. They have nighttime symptoms frequently, like almost every night, 7 times a week. Their FEV1 is very low, less than 60%, and they're having to use their short-acting beta agonist at least twice a day, which is pretty frequent. So these people would be on similar inhaled corticosteroids, this time a high dose with a long-acting beta agonist. And this is, of course, in addition to their rescue inhaler that they're using at least twice daily. So let's get into a bit more detail about the drugs. We talked about the short-acting beta agonist. Some examples of these are albuterol, levalbuterol, or pyrbuterol. The main mechanism here is that it's a bronchodilator, and these are pretty common. You can use them frequently. One important thing to check with somebody who's using a rescue inhaler is to make sure they're using it correctly, because oftentimes in asthma treatment, we are tempted to increase the drugs that they use, to increase the severity of the drugs, but in reality they just need to know the better technique for using their rescue inhaler. So that's something to check, something that can be added to this warning. Make sure that the technique is proper. Second class, inhaled corticosteroids, that's like budesonide or beclomethasone. These are anti-inflammatory, and they don't have systemic steroid effects. So the systemic steroid effects are listed here, so they're pretty benign drugs that you do want to use them regularly. Next is the long-acting beta agonist. So this is like formoterol or salmeterol. These are bronchodilators again. One warning here is that you don't want to use these first. You want to kind of work your way down this list. This is stepwise treatment, and this list is kind of roughly an increasing severity of disease as you go down this list. But you don't want to use these without inhaled corticosteroids. And if you do use long-acting beta agonists without the inhaled corticosteroids, you can build tolerance to the long-acting beta agonists. It can reduce your sensitivity so they won't work as well, and it predisposes you to more severe and more frequent asthma exacerbations. So it can actually make your symptoms worse if you're using it without the steroids. So always combine the inhaled corticosteroids and the long-acting beta agonists. And you'll notice on the previous slide that every time you used the long-acting beta agonists, it was always in conjunction with an inhaled corticosteroid. Another category is the anti-muscarinic drugs. This is like tiotropium and ipratropium. These decrease secretions and they're bronchodilators. Another category is the monoclonal antibodies. These are a bit more expensive. I guess that might be something you would put in this negative column. This is like omalizumab. These are good for people that have high IgE or high IL-5. So I think this is an actual anti-IgE, and one of these is an anti-IL-5. So if you have comorbid allergies, if it's a kid that has pretty bad eczema, pretty bad asthma, they might benefit from the monoclonal antibodies. And then one of these medicines kind of last resort for somebody that has really refractory, really terrible asthma are the oral steroids. So this is like prednisone. These are generally strong anti-inflammatory drugs, but they do have a whole host of side effects, like osteoporosis, like changes in the skin. It can make your skin thin. It can make your skin kind of have these marks like striae. And it can also cause fat changes, like fat redistribution, or it can cause you to have central adiposity or fat distribution on the face, moon facies. Some of those characteristics are collectively called Cushing syndrome, which is when you're exposed to too much steroids. So you really want to try to get patients off of the oral steroids, but they can be used kind of as a last resort for really refractory asthma. Also on this slide, it's worth mentioning that all asthmatics should get the flu and the pneumococcal vaccine. They are at risk for those. Lastly, let's talk about what to do in the case of an acute exacerbation. So first, you want to diagnose that they're actually having an asthma acute exacerbation. One way to do that is to look at the alveolar arterial gradient on arterial blood gas. So this is the amount of oxygen in the alveoli and the amount of oxygen in the arterioles, and you look at the gradient between those. If it's high, that makes you think asthma. They will also have low peak expiratory flow, so this is kind of based on their normal individual levels. Now, you're using peak expiratory flow now instead of proper pulmonary function tests because you can't really measure pulmonary function tests when somebody has acute dyspnea. When somebody's really short of breath and really kind of struggling to breathe, you're not going to get accurate readings on pulmonary function tests. So this peak expiratory flow is an approximation of their FVC, and you'll do that kind of in the acute setting. The treatment for acute exacerbations of asthma include albuterol, ipratropium. This is an inhaler or a nebulizer, and you can do that every 4 hours. You can give them IV steroids. Hopefully this will be a short course, again, because we talked about those side effects, but if it's an acute exacerbation, you really want to take care of it. You can give them supplemental O2 as a cannula straight to their nose, and magnesium has been shown to help. That's a bronchodilator. In the case of last resort, if somebody really isn't responding to these treatments, to the bronchodilators, to the steroids, to the supplemental oxygen, you might have to give epinephrine, and you might have to resort to endotracheal intubation. This has been a short video on asthma, overview of asthma. I hope it was helpful, and thank you for listening.